Good afternoon, ladies and gentlemen. We start now. Professor Dr. Hamda Abazim, endocrine treatment in postmenopausal metastatic hormonal receptor in breast cancer, monotherapy versus combination, supported by Novartis.
Bismillah ar-Rahman ar-Rahim. Good evening. Yes, it is good evening. Not good afternoon anymore. So my task is to talk with you today on how we optimize the endocrinal treatment in the postmenopausal women in the first line setting. Let's go straight to the clinic. It's a clinical case. This is one of our colleagues, Dr. Mona. She is an obstetrician, 57 years, postmenopausal woman, working heavy load of work, 5 days a week, 8 hours a day. Presented to the pulmonologist by dyspnea on exertion, not severe, cough, persistent cough, described as dry cough, and this was not improving under medical measures, with some progressive pains in her lower back and both hips. Not severe pain anyway. The pulmonologist asked for this CT, and here we are. That's why she was referred to us. She has this kind of bilateral hilar masses, very huge on the right side, multiple small pulmonary nodules. Performance status according to the ECOG was 1. When she was examined, we found this. The right axilla, or probably you call it breast tail, something lobulated that we felt. The CT confirmed this. The ultrasound showed it's a right axillary breast mass with dominant right axillary nodes. The radiologist inserted a needle, and the pathology is ER positive 7/8, PR positive 7/8, HER2 negative, grade 2. And the PET scan, it shows this kind of osseous metastasis, not very dominant, but that is there. And of course, here we are, the pulmonary disease, hilar, mediastinal, and pulmonary disease. Now the question of my talk will focus on, in this particular patient, would you treat with an ER positive, HER2 positive, ER positive, PR positive, highly positive, HER2 negative, metastatic de novo breast cancer? Would you treat in this case by chemo or endocrinal treatment? Mind you, she's not in visceral crisis. Her performance is 1. Okay, who would give chemo in this patient? No one will give chemo? Only? Okay. Then who will give hormonal treatment in this patient? Yes, majority. Great. That's a very good job. I think Dr. Hugo could really convince you about the importance of first-line endocrine treatment. But how did we learn this? How did we learn that endocrine treatment is as effective as chemotherapy when it comes to overall survival in the first-line setting? From this Cochrane review, which showed that in these studies, that if you start by chemo or you start by hormonal treatment, you will have absolutely no difference in overall survival. Of course, you may expect, according to these studies at least, some improvement in overall survival and in overall response rate by chemo, which was not confirmed in the 2 large studies. Toxicities, of course, was higher with chemo. But the conclusion actually is that in this kind of disease, if you start by chemo, it is not really recommendable, because endocrinal therapy can give similar overall survival unless you have rapidly progressive disease. This was the term at that time. Now we call this visceral crisis, probably. And my own concern about this kind of Cochrane reviews is that modern endocrinal therapies were not included in this trial. We did not have the modern endocrine treatment as well as they included patients with HER2 positive and hormone receptor positive in this analysis, which would favor chemo, certainly. In more recent trial, for the real-life experience coming from Netherlands, patients with metastatic disease, with ER positive, HER2 negative, if they are referred to doctors in Netherlands with bone metastasis, the vast majority will give in these patients hormonal treatment as first line, while if they have visceral metastasis, they tend to give more, not visceral crisis, they tend to give more chemotherapy in 1/3 of the patients. The bottom line in this trial, at least in this study, is that when chemo was first given or hormone was first given, the overall progression-free survival was much better with hormonal treatment and also overall survival. But if you insist to think about chemo, let's go and see what kind of benefit you expect from chemo with or without bevacizumab in this population. We have now just in front of you Dr. O'Shaughnessy. She's sitting in front of me. Thank you for this meta-analysis, because by doing this meta-analysis, we knew that in the first-line setting, if you add beva to chemotherapy, you will improve significantly the overall response rate from 30-something to almost 50%. So beva will improve overall response rate. If you care about that, progression-free survival improved from 6 months to 9 months, again, significantly. But please look at this. During the first 6 months, the progression of patients receiving chemotherapy was in the range of 40%, 45%. They will progress during the first 6 months. While patients who are receiving beva, you have still something like 30% of the population, they will progress early. Certainly, this kind of studies of HER2 negative patients, they included population of hormone receptor positive and hormone receptor negative. And we care, of course, of hormone receptor positive here. That's hormone receptor positive, HER2 negative. The progression-free survival with beva is 10 months, with chemo alone is 8 months. Okay, a lot of side effects, needless to mention. And in another trial with Dr. Rugo again, we have first-line beva for all patients with paclitaxel or nab-paclitaxel or exabifolone. Now the response rate is in the range of 40% for paclitaxel with beva, and the progression-free survival very identical to the meta-analysis in the population of ER-positive, HER2 negative. It is from 10 to 12 months. So that's the best you can achieve with a lot of side effects in the first-line setting in this population, period. Now, if you wish to think about endocrinal treatment, we have many studies in the neoadjuvant phase and metastat and in the using chemotherapy to tell us that luminal subtypes, they do not respond highly to chemotherapy, and neoadjuvant endocrine treatment versus neoadjuvant chemotherapy in these patients, they will yield the same overall response rate. So in the metastatic setting, we have seen many evidences that if you give chemo in the first line, you don't gain anything in progression-free survival and overall survival. With the modern chemo, what should be your expectations in the first line setting? If you give aromatase inhibitor monotherapy, you will have progression-free survival in the range of 14 to 15 months, and you give fulvestrant in this population, you will boost the progression-free survival by something more than 20%, almost 20% more gain in progression-free survival. Mind you, you do not have higher overall response rate or higher clinical benefit. That's not bad at all, and here we are, that's the Falcon trial to tell us so. But again, during the first 6 months, you have something between 20 to 25% of the population will progress early, whether you give fulvestrant or you give aromatase inhibitors. That's what we call de novo resistance. The remaining patients will almost always subsequently relapse. We call them secondary resistance, and the question is very solid. How can we improve over these results? And here we are, the role of cycle-independent kinase 4 and 6. We know that the cyclin-dependent kinase 4 and 6, they work dependently on the presence of cyclin D. They form complex together, and they promote the progression of cell cycle from G1 to the S phase. Importantly, in breast cancer endocrinology, the cyclin D, cyclin-dependent kinase 4 and 6 axis is critical for the estrogen receptor-induced proliferation. So the proliferation induced by estrogen actually is mediated by this complex. In breast cancer, we have many reasons to believe that we have upregulation in this pathway, which is involved in the endocrinal resistance. In the preclinical model, we know that we have beautiful synergy between cyclin-dependent kinase 4 and 6 and aromatase inhibitors or tamoxifen. And we have now in the clinic, we have 3 approved drugs. They are all cyclin-dependent kinase 4 and 6 inhibitors, but they do not have the same exact pharmacological effect on the cyclin-dependent kinase 4 or 6. Abemaciclib is the most potent to suppress these kinases, and it suppresses also other kinases. And if you see this kinase selectivity tree, the bigger red balls or red circles with abemaciclib, it means it inhibits more kinases at these sites, which will bring certainly different toxicity profile and maybe some efficacy differences. Anyway, the palbo and ribo, they have more or less similar profile in pharmacokinetics as well. And we have, at the present time, 3 studies in the frontline setting to tell us whether you use the abemaciclib or ribociclib or palbociclib. Probably you have the very same benefit compared to aromatase inhibitors. You improve progression-free survival by something like 45%, and you improve response rate. Now the response rate is touching the level of 40 to 50%, something like what you achieve by chemo. But look at the rate of discontinuation of the agents. You can see with abemaciclib, you have a very high rate of treatment discontinuation because of side effects compared to ribociclib and palbociclib. Anyway, we have seen this several times. In the first-line setting, the Mona Lisa and Paloma, they have very, very more or less similar patients population. The majority, they have visceral metastases, and 1/3 of the population was de novo treated. De novo presented. The progression-free survival, the hazard ratio was exactly the same, and you can really delay the onset of early progression by something like 10% at 6 months compared to aromatase inhibitors alone. Now you can see the patients with measurable disease, the overall response rate is 53%, and this was significantly higher than aromatase inhibitors alone, clinical benefit touching the boundary of 80%. So this is very impressive. Side effects, you know, this kind of drug, they induce high rate of neutropenia, grade 3 and 4, but neutropenic fever was quite low at 1.5%. You have some, cumulatively, you see some anemias and thrombocytopenias in the grade 1, basically grade 1 and 2. And alopecia is increased, and you have to take care of that. Nausea, diarrhea, vomiting, very mildly increased. No increase in infection, increase in liver enzymes, but you have to monitor this, and liver enzymes will come back to normal following the interruption of the drug. Importantly, we have to take care of what is known as prolongation of the QT interval induced by many drugs. Ribociclib will induce around in 3% of the population this kind of toxicity, that it can resolve spontaneously if you interrupt the medications. Bottom line, the front line, ribolitrozole, like other aromatase inhibitors combined with cyclin-dependent kinase, they will give you marvelous prolongation of progression-free survival that exceeds 2 years, response rate in the measurable disease in the range of 50%, and they delay early progression. This is very important, especially when you have visceral metastases. And as such, these data are much more favorable compared to what you gain by chemo and Beva in the frontline setting. And here we had in the last March, we had the FDA approval for this combo. Now, let's go back to our patient, the gynecologist. Now, she has performance status of 1, and she has some symptoms related to the chest intrathoracic disease. The PET scan showed lots of mediastinal nodes, axillary nodes, lots of bone metastasis, and a very dominant pulmonary pathology. And the alkaline phosphatase was 3 times elevated. The CA15-3 was more than 5 times elevated. The ECG was, the QT interval was 410 milliseconds. And in the guidelines, it will tell you if you have visceral crisis like this, then give chemo. But if you don't have visceral crisis, and our patient did not have a visceral crisis, if you have only visceral metastasis like this, you can go for the hormonal treatment. You know whether the combinations or the monotherapies. Anyway, we discussed with our patient the results of the Mona Lisa, and she's a gynecologist, as you heard, and she was concerned about 4 main questions. The benefit of such treatment in the presence of lung involvement, this kind of lung involvement. The benefit of such treatment in de novo metastatic breast cancer. Will it take long to achieve response? Because we know the classical concept is that endocrinal treatment, the monotherapy endocrine treatment, they are slow in inducing responses, and the quality of life while receiving the treatment. For the 2 first questions, the presence of lung metastasis, would it gain benefit? The answer is yes, as you see from the subgroup analysis here. The benefit in the presence of lung or liver metastasis was equivalent to the absence of this metastasis. Again, for patients that newly diagnosed, it's very clear that at least they are doing the same, if not a little bit better, compared to patients with prior treatment. And Dr. O'Shaughnessy, once more, she provided this survival curve, the Kaplan-Meier, for patients presented with de novo metastasis, like our patient. You can see that at 1 year, you have 16% difference in progression-free survival. More impressively for me, at 1.5 years, the curves are still separating, and the gain in progression-free survival now is 35%. Would it take long? Actually, that's how it goes. If you give letrozole alone, at 2 months, you have something like 10% with response, and with the combination, you have something like 20% of response. At 4 months, you have even more separation of the percentage responding. More importantly, for you in the clinic, you can witness some regression in the measurable disease in 3/4 of your patient at 2 months. This is very impressive, and I think no chemo can provide similar figures. Quality of life, we have the quality of life data to show us that with this treatment, you have, whether you give aromatase inhibitors in green or the combo in blue, you have improvement in the quality of life with this kind of treatment, meaning that this kind of treatment is very effective for the patients. And it starts to improve, and at 2 years, it's still maintained at improvement. There is some numerical differences in favor of letrozole alone, which was not clinically significant. The time to deterioration of the quality of life was again overlapping. That is in blue for the combination, in red for the letrozole alone. That's very important for the patient, and I want you to show this for your patients with pain, because if your patient, if she has pain, then the pain will decrease more significantly with the use of the combination compared to letrozole alone. So the bottom line, Mona Lisa 2 could tell us that there is maintenance of the quality of life and there is meaningful reduction in the pain scores. So we discussed this with Mona. She accepted to start the treatment, and it was given as the classical ribociclib, 600 milligrams per day, 3 weeks on, 1 week off, plus letrozole with denosumab. And with denosumab, we prefer to give high dose of vitamin D, and I'll tell you why later, and high dose of calcium. CBC at day 15, it relieved grade 3 neutropenia while the QT interval was still normal. The serum electrolytes were normal. Okay, I'll need a couple of minutes, please. There was no febrile neutropenia at that time. Again, after 1 week, we repeated the CBC. Again, she was still in grade 3 neutropenia with no neutropenic fever. And 1 week later, it recovered to grade 2. And at this point, we decided to resume ribo at 400, not 600, because we have 2 readings of grade 3, and the ECG was all the time normal. In the Mona Lisa study, this happened, and you have to know that if you give this kind of medication, something like 77% of the population treated with this treatment, they will have a sort of dose interruption, with 50% having dose reduction. So this is the very common scenario in the treatment of these patients. The follow-up notes, the patient, she improved dramatically within the first few weeks of treatment on the clinical grounds. Her tumor markers dropped consecutively, and her ECG was all the time at 410, and we did not repeat the ECG after month number 4 because there was no evidence of QT interval prolongation, which usually happens during the first 2 months. And here we are. That is the disease at the beginning, and that's the disease at 6 months of treatment. That is the intrathoracic disease. You can see here, it is all cleared. The pulmonary metastasis, the tiny pulmonary metastasis, they are all cleared. The bone, again, it was cleared in the hip bones, while in the lumbar spine, we still have some activity, and this is mounting to partial remission in the bone. The final take-home messages are very simple. In the absence of visceral crisis, endocrinal therapy should be considered in the frontline therapy of all patients with hormone receptor positive HER2 negative. Certainly, aromatase inhibitors combined with any of the 3 cyclin-dependent kinase 4 and 6 inhibitors, they represent the most effective therapy in these patients. The main core and subgroup and exploratory analysis of the Mona Lisa, as we have seen, have shown several clinically important data very relevant for the patients. First, this treatment can maintain the quality of life over time as good as letrozole. They decrease the pain scores more promptly than letrozole. They will have early onset of objective responses more promptly compared to letrozole, and they have equal therapeutic gain in patients with visceral metastasis versus non-visceral metastasis. The last take-home message actually is not for you, it is for Novartis. Drug accessibility is crucial everywhere in the world, except especially in our own country. And finally, a big thank you for my team for supporting me to treat these patients. Thank you.
Thanks, Professor Hamdi, for this elegant presentation. And as we are too late, question will be delayed to the end of the session. Okay?
Thank you very much, Prof. Hamdi. Always a great talk, as usual. My name is Ahmed Saaduddin. I'm a consultant clinical oncologist with long-term interest in hormone-dependent breast and prostate cancer. And I thank Dr. Hisham and his team for the invitation. Dr. Hamdi addressed the issue of hormonal treatment in postmenopausal. Most of the studies were addressing this cohort of patients, but unfortunately, the same attention were not given to the premenopausal cohort. And we are delighted to have Prof. Joyce Oshinezi, who will, from Dallas, Texas, Baylor Cancer Center, who is co-directing the breast cancer research chair, and she has a well-known interest and publications addressing the issue in premenopausal. I think we are all eager to listen to her. Thank you very much for coming.